give you the history.
Okay, sure. Sorry, Dr. Khan, how would I do that actually? Um,
Candidate 2, do you know how to ask for mouse? If you can unmute yourself and tell candidate
Uh,
1.
Sure, doctor. Kindly go to the view option, preset, and request remote control. Yes, view option in the top.
oh,
Yes.
oh, the view option.
Yeah. Have you seen it?
It's not there for me.
In the top of your screen, you will find view options.
Yeah, but when I click on it, it doesn't.
Yeah. Click on it. You will find request remote control. Click on this arrow.
Oh, that option isn't there for me. I don't know why.
Mm.
Candidate 1, you're finding it difficult?
Yeah, sorry, Dr. Khan, that
Should I
option is.
scroll for you?
Okay, sure.
Yeah, it's not an ideal situation, but let me scroll for you. And in future, for everybody, whoever wants to come as a viva candidate, if you can, with your colleagues, just do a dry run about this, how to ask for mouse. Now, this is a 70-year-old road traffic accident A&E case. And I am going to start from the top, and I'm coming down. Just keep looking, then I will actually come from down to up to give you a second look. I'm not expecting you to talk till now because of this limitation. Right. So, candidate 1, let's start.
Sure.
You can hear me? Yeah, please.
Yes, I can hear you. So there are multiple areas of hyperdensity on this non-contrast CT head with the axial projection shown. Within the left frontal parietal lobe, there is a pacemaker extradural hematoma, and within the anterior right front uh, temporal lobe, I think the right temporal lobe, sorry, I think there's a small subdural in addition to some intrapolar chimal hemorrhage as well. In my routine practice, I would review all the other available projections to look for any other areas of hemorrhage. There's also some parathyroid hemorrhage at the region of at the level of the lateral ventricles as well. In addition to multifocal peripheral areas of hemorrhage suggestive of contusions, there's no hydrocephalus. Yeah, as I mentioned before, in my routine practice, I would like to review the images in multiplanar format. I will also look for any associated fractures.
How will you look for a fracture?
On the bony reconstruction specifically.
Do you see anything?
So yeah, so within the left frontal parietal lobe, at the area of the extradural hemorrhage, there is a minimally displaced, a minimally comminuted fracture. with some overlying soft tissue swelling within the skull. I don't see any further fractures.
What is this? Do you see my mouse? What is
Yes,
this?
I thought this was I described it as a parathylacine area of hemorrhage.
Where is this hemorrhage?
It's just posterior to the lateral ventricle. So I mean,
Right. So, anything else? This thing, you have described it as an intraparenchymal hemorrhage?
yeah,
How
it
did
just
you
doesn't.
describe it?
It has a similar appearance to the other focus that you just pointed out as well.
Okay.
It kind of
Also
doesn't.
mention, yeah, let me ask you a few questions. You have also mentioned some contusions. Where were these contusions?
I thought more superiorly as we go towards the vertex, there are some areas of kind of cortical-based hair densities. Because of their superficial location, I thought they could represent possible contusions, but they might be microhemorrhages, actually. I think given the overall appearances.
So what is your conclusion?
In summary, the images I'm presented with demonstrate multifocal hemorrhage within the brain of this patient, both intra and extraaxial. There is an associated fracture overlying the left frontoparietal skull. I would
Okay,
like to,
stop here.
yeah.
Thank you. Thank you. Now, the first case is brain trauma. We have got various kinds of injuries, and these include contusion, diffuse axonal injury, subdural hematoma, extradural hematoma, subarachnoid hematoma, fracture. We also have got a bit of herniation, bit of midline shift, etc. Now, all of these words and the concepts behind it should be known, and the marks are going to be, because there are many findings and it's easy to sort of uh, get those findings. But having said that, we should have a clear-cut concept of how to call what to call. Now, this chart here tells you that there are three types of injuries: primary brain injury, which happen at the time of trauma, secondary effects, and delayed effects. Now, primary effects include contusion. So contusion, there are only two types of parenchymal injuries. One is contusion and one is diffuse axonal injury. And these words should be used to describe them. And then there are hemorrhages, extradural, subdural, subarachnoid, and there are fractures. Secondary effects include herniation like subfalcine, transtentorial, etc. And of course, there can be secondary edema, ischemia, etc. And there can be things like dissection. And these are the delayed effects of trauma. Everything is extremely important for the exam. But I just want to confine myself to the present case. Now, a quick recap that contusion, basically, contusion is injury to the surface of the brain, and surface of the brain is gray matter. So by definition, the skin of the brain must be involved in contusion. And of course, deep through the skin is the white matter. It all depends on the severity, and that can also be involved. Of course, there's a concept of coup and counter coup injury. Now, this is a hemorrhagic contusion. Key point is that the surface of the brain must be involved. And with that, contusions can be hemorrhagic, non-hemorrhagic. When they are hemorrhagic, they can have punctate high density like this, call it a contusion. Don't call it an intraparenchymal hemorrhage in the context of trauma. These are the sites of contusions, and generally speaking, where the brain is touching the base of the skull, particularly in subfrontal region, etc. Contusions are more common. Diffuse axonal injury, please remember, is a primary brain injury. And the mechanism of action is very important, where sudden acceleration and deceleration causes stretch of the axons and they are shared or disconnected. When this happens, then on a CT scan, there can be, they are difficult to see. Why? Because 80% of them are non-hemorrhagic. So you will not see them. On the other hand, about 20% are hemorrhagic, and then you see, and that is why they become an exam type of a case. There are specific, very specific sites where you have to look for diffuse axonal injury, which includes, at the gray white matter junction, corpus callosum, brainstem, cerebellum is a bit rare. Now, these are anything which is red. You must remember that on this diagram, diffuse axonal injury. And this is what the examiner is going to ask you. Now, this is the splenium of the corpus callosum. This is gray-white matter junction and gray-white matter junction. And of course, it can happen in the midbrain where the prognosis is very bad. It can happen at other places also, but the green color here is depicts a bit of rarity. So this is diffuse axonal injury. And if you see this case, in diffuse axonal injury, another thing which you have to remember is that these patients will be clinically very bad. At times Glasgow coma 5, 6, 7, and the CT will not be all that bad. If you're a neurosurgeon and the CT is normal and the patient is Glasgow coma 7, you just label it actually diffuse axonal injury. You infer that this is diffuse axonal injury. Nobody can do anything about it. Time will tell about the recovery. But in the exam, you have to develop your eyes. Now, if you see, this is a classical exam case where we have got punctate high density at gray white matter junction. So call it diffuse axonal injury. This one has more than that. If you see here, there are some densities in the splenium of the corpus callosum, some hemorrhage there. And so this is another diffuse axonal injury. If nobody does a MR just for the sake of it, but sometimes it is done as a prognostic criteria. Patient is not responding. You do an MR, and on MR, non-hemorrhagic diffuse axonal injury will be better seen on fluid-sensitive sequences, maybe FLAIR T2, whatever. But the key sequence, which is the exam sequence, is a T2 star, which is a gradient echo, or SWI, where you will see low intensity foci at the classical locations, but they will be more elaborative. They will be more than what you see on CT because the sensitivity is very high. This is from Chapman 13.4 microhemorrhages on MR. And other than all of these things, diffuse axonal injury, you see this thing, number 1 on the list. Acute shearing injury, acute trauma, this must be high up on your list. Now, let's go through the case. Now, this case is a classical case, which is easy case, but the marks will be according to your description and according to the findings and how do you describe it. So the key thing in an easy case is that you describe and your concepts, etc., will be checked. Now, this thing here is a contusion. It is not intraparenchymal hemorrhage. Call it a contusion. The gray matter is involved. The surface of the brain is involved. There is a concept of enlarging contusions, etc. But the key thing is that the surface of the brain is involved. With that, there is a lot of hemorrhage and surrounding edema. Now, you did pick up well the subdural hematoma, which was here. This thing is an extradural hematoma, and you did well there. By the way, you were asking for multiplanar. You should not ask for multiplanar. That is the end. You will say that on this axial, what you can see. You have to ask for a brain window on this axial. It is fine to, in the end, to sum up that in my usual practice, I will do multiplanar. But first of all, tell the examiner what is happening on this axial. And the bone window should be asked on the axial. Now, there is a depressed fracture also. But all these findings are, quite obvious. Now, here comes the fine touch. This is splenium of the corpus callosum, and this is diffuse axonal injury. And as we go up, you can see traumatic subarachnoid hemorrhage filling up the sulci, right and left. Please remember that trauma is the most common cause of subarachnoid hemorrhage, and we call it traumatic subarachnoid hemorrhage. And so all of this is subarachnoid hemorrhage, right and left, etc. And then there is a midline shift. You know, the pertinent negative positives are midline shift. This patient also has a lacunar infarction, which is of no significance, but just an observation. Now, there is subfalcine herniation to the other side. And if you see the midbrain here, now this is the ambient cistern, which is slightly effaced and maybe early transtentorial herniation, but not frank transtentorial herniation is visible. So the key point is that try to be more elaborative in these kinds of cases, describe the findings and in detail, and the marks will be given. To pass this case is easy, but your aim should be to get maximum marks. Okay, next case. Just 1 second, please.
Dr. Khan, I think I've managed to find the request control. I've just done that.
Sure, that's very good. But just 1 second, please. Okay. Now we have got your second case is a 58-year-old female, severe backache and sciatica to, she presented to A&E. Rule out cauda equina. Over to you, 58 female.
Sure. So I'm presented with a sagittal T2 sequence of an MRI lumbar spine. Just going to take a moment to review the images. Sorry, it's jumping a little bit. So an initial assessment, I can see that there is a diffuse infiltrative process throughout the entire segment of the imaged cord. This appears to be occupying the thecal sac, particularly posterior to the spinal cord. At the inferior region, at the level of the L5-S1 region, there is more diffuse involvement, which likely involves the nerve roots at this level. The cord itself, as far as I can see, returns a normal signal throughout, and there's no other abnormality that I can see. In my routine practice, I will also review the other sequences available, usually a T1 or stir sequence.
This is a T1.
Oh, sorry, it's a T1, sorry.
No. You were looking at T2. Now I have given you a T1.
Oh.
Yeah.
Oh, sure. Oh, sure. Thank you. So again, the T1 sequence demonstrates this florid kind of leptomeningeal thickening along the thecal sac. Well, is there a contrast sequence available at all? A T1 post contrast.
And why do you want that?
I guess because the imaging findings are suggestive of a diffuse process. So in my in my assessment, my top differentials for this would be a would include a malignant process. Although that would seem slightly unusual given the kind of their contiguous appearances. Infection is also a possibility.
So this is a post.
Yeah. Sorry, I didn't hear that.
This is a post-contrast sequence.
Okay. So there is enhancement throughout within the area described, and this enhancement is very homogeneous. In terms of malignancy, I'll be thinking specifically of lymphoma. Infection, I'll be thinking possibly of TB. It could also be
Sorry, what is your finding? What is your finding?
Just a diffusely enhancing leptomeningeal enhancement.
Where is the enhancement? Can you point it out to me?
Further up the.
Okay.
My differentials for this would include
what is your differential for
malignancy, specifically lymphoma. Infection would include TB, but there's no associated bony involvement or epidural abscesses. So that would be slightly lower than my differentials. Sarcoidosis may also give this appearance as well. I would like to correlate with the axial slices at the slice of interest, and I would like to compare with any previous imaging to see if this is a new finding. If this is a new finding, I think one way to differentiate between these differentials would be to discuss the clinical history with the clinical team, and I would also like to image the rest of the neural axis.
Okay, thank you. So now, this is spontaneous extradural hematoma, and this patient is on anticoagulants. We'll come back to the scan. Now, a bit of a recap of the basics. Now, the basic sequences of spine include a T2 weighted sequence, then a stir sequence, and then a T1 weighted sequence. These are the basic sequences. Actually, stir is done when it is required. Otherwise, T2 and T1 are the basic, particularly the sagittal sequences. So you have to develop your eyes on that. A stir sequence, by definition, is a fat saturated sequence, and anything edema, bone marrow edema, spondylodiscitis, that kind of clinical, it will show very well. And now we also use the stir sequence to pick up cord lesions, particularly in cases of MS. And the sensitivity is more than other sequences. Now, then when you do post-contrast sequences, you should do a fat-saturated T1 weighted sequence. Fat-saturated T1 is this one, and this is a post-contrast sequence. In this particular case, there are some dural, metastases which are enhancing. So these are the key sequences. Now, candidate one, the way you tackled it, you were slightly off your final because you did not ask for a pre-contrast. You should have asked for pre-contrast, and then you would have understood the diagnosis So that will be my feedback for you. Now, there is a differential diagnosis in your Chapman, which is 2.17. This actually covers whole of the spine. It is beautiful, and extradural, intradural, extramedullary, intramedullary, and cauda equina lesions are what is mentioned in this one. And epidural hematoma is one of them. Typically extends over multiple vertebral segments caused by trauma, intervention, or coagulopathy. Beware about this, what I have shown you. And uh, it all depends on how chronic it is, because you can see a T2 low signal, which is siderosis, but usually it is high signal, like our case. Now, this is the differential diagnosis. Just a bit of anatomy of the cauda equina. Cauda equina is very important for your exam. And candidate one picked up very well, where immediately his eyes went into this, that something is abnormal. Because usually this is the conus and this is the cauda equina, and this is how it should look like. Our case was not like this. Look at this one. This is a slightly different pathology, again an exam case, but uh, showing you that this is cauda, the conus. And look at it, something is filling it up. It should not have. This is a pre-contrast T1, this is a T2. And as if the nerve roots are thickened. Now this is the type of case in which you will handle like this. After you will do contrast, then pre and post contrast, you will compare. First of all, develop your eyes on axial on this one. And you can see that each and every nerve root is thickened, each and every nerve root. That is why it looks like this. When you give contrast, though it is not fat saturated, but you can see that these are enhancing. This is a case of what we call lymphomatous meningitis, which is a type of manifestation or presentation of lymphoma. Of course, in this case, other differential like sarcoidosis, metastasis, etc., you can consider. Now, this is the differential diagnosis, lesions related to cauda equina, extremely important, extremely important. This one is GBS, as in Guillain-Barré syndrome, in a 3 months old baby. And you can see on post contrast, whole of the conus is enhancing. And actually, if you look carefully, the nerves are enhancing. On this axial, you can see that the nerves are also enhancing. So Guillain-Barré is, of course, if you see here, these are the various differentials. This is GBS and other entities. So sarcoidosis should always be in your differential. Please remember that candidate one did well, where sarcoidosis he did consider, but the problem was that he did not ask for a pre-contrast, and that is why he thought that it is enhancing. Actually, it was not enhancing, it was high intensity on pre-contrast fat saturated sequence. Otherwise, sarcoidosis is what we call biggest mimicker in neuroradiology. So it can do many things, and you can consider it even in brain. This is a case of trauma. Just to develop your eyes on this, that there is a fracture here, and you can see some high intensity here. You see this high intensity, and this is a hemorrhage. This is hemorrhage which is going here. Now let me go through the case quickly. And so the key thing is that it was very well picked up on this T2 weighted sequence that something is wrong and something extra is there. This is the conus, and what is this? Something extra is there. So then I showed a T1 weighted sequence, which is this one. And again, this is it. So the key thing which was missing, that post-contrast T1 weighted sequence was asked. This is a post-contrast. And the inference was that this is enhancing. Actually, a pre-contrast T1 weighted fat saturated would have solved the matter. Here you are. So this is a pre-contrast T1 weighted, and this is all high signal intensity. Of course, there is a role of, what we call axials also, because on axials, we can see this high signal here. And on T2, of course, there is compression. So this is hematoma. Okay, good, well done. Candidate 1, your last case. This is a 76-year-old acute abdomen male patient, A&E patient once again. Over to you.
Sure. Just going to see if I can scroll. Oh, I've requested control.
Are you asking? Yeah.
Yeah.
I've granted the mouse to you.
Perfect. Yeah, it's scrolling for me now. Yeah. So I'm presented with an axial slices of the seated abdomen pelvis with contrast for this adult patient. Just going to take a moment to review the images. Sorry, it's a little bit slow.
Yeah, take your time.
So on initial assessment, I haven't seen anything grossly abnormal in terms of key findings. Really. So I just want to review the pelvis again.
Just concentrate on the left iliac fossa where the maximum tenderness is.
Okay, sure. I'm really sorry about the scrolling. I'm not sure yet. So I haven't seen anything obvious, but I thought when I was scrolling up that there was
Okay, just 1 second. Don't move the mouse. Just concentrate here and what is happening here. Don't move the mouse. I am moving the mouse. Now, just concentrate in this area and try to work up what is happening in this area. Over to you.
Yeah, so I initially saw this abnormality. I was trying to work out whether this was the possibly the urinary bladder, because there's a quite large
So you can move the mouse now. I've taken you
free
can move the mouse.
Sure. So I can see that within this pelvic structure there is quite a large free locule of gas. I'm just trying to determine what structure it is, whether it's within the bowel, or within the urinary bladder. So it seems to me, because I can't see the urinary bladder elsewhere, I think this is the urinary bladder, and it's really that is very thick walled with some adjacent fat trending, and this clearly there's a locule of gas within as well. I don't see any distance.
Are you intentionally not moving the mouse or you are trying to move the mouse? Yeah. So give me your final conclusion, please, or whatever you were telling, please.
Yeah, so in summary, this CT abdomen pelvis demonstrates some free gas locule within the urinary bladder, I'll be suspicious for an acute vesical injury. In my routine practice, I will review the rest of the images for any further acute findings, including any bony fractures within the pelvis. I would like to inform the clinical team urgently and also recommend doing a CT cystogram for further delineation as well.
Okay, thank you. Now, this is a case of diverticulitis with colovesical fistula. Diverticulitis with colovesical fistula. I'll go through the case subsequently. Now, please remember, diverticulitis is an extremely important condition for the exam, and there is a spectrum of findings which can come in the exam. From just a basic concept is, first of all, diverticuli or diverticulosis is extremely common in UK. And there are some, whatever the factors are, but it is so common that that is why diverticulitis presents so commonly. And basic pathology is that diverticula actually ruptures and it causes inflammation in the adjacent. Most common site is the sigmoid mesentery. So it will cause a bit of inflammation there. There can be, air bubbles. So this is just diverticulitis, which is minimal diverticulitis. But from there, there can be a spectrum of findings, abscesses, fistulas, fecal peritonitis, etc. Look at this case where we can see that next to the colon, there is a large abscess. And you should have a clear-cut concept that this is a surgical classification. You don't have to learn it, but this is a to-be type of a scenario where the examiners are going to ask you, what are you going to, if there is an abscess, this one, you see up to 5 centimeter abscess. The concept is that surgeons do not want to go in. They don't do any surgery. And they will, so you are going to tell the examiner that I'm going to offer to put in a contrast, and they might ask you some IR type of questions. So this concept should be there, the management. And of course, there will be what we call, if there is peritonitis, etc., full ascites with it, or pneumoperitoneum. Another key point for you to remember is that if there are gas locules in the sigmoid mesentery, don't overcall them. Don't think that this is frank pneumoperitoneum. Frank pneumoperitoneum will be when the gas is under the diaphragm at some other location, things like that, because this one will be tackled conservatively. Now, diverticulitis is also important for barium examinations, which still come in the exam. So I warn you on that. And your generation, you don't do bariums and you will always struggle on that. This is a classical exam film where you can see a bit of diverticuli here and here and here. And with that, there is a rectovaginal fistula. So let me go through the case. Now, if you see here, the key finding is, now look at this colon, and you can see so many diverticuli right and left, innumerable diverticuli. Now, with that, as we go down, we can see, look at this, something is there. Now, this something, just keep tracing it. And actually, this is a fistula which is tethering the superior fundus wall of the urinary bladder. And then if you look carefully, there is an intramural abscess. And actually, if you go right and left, you can see that it is tracking inside. And then with that, within the bladder, you can see that there is a lot of gas and there is perifocal fat stranding. So on an axial, you can make out that this is a colovesical fistula. And of course, once you see it, it is absolutely justified to tell the examiner that in my routine practice, I will confirm it on other, uh, sequences, which is fine. But uh, if you have made up, look here, just to show you that this is, and this is that fistula, how it is tethering the bladder superiorly, how the bladder wall is thickened, and then it goes in. This is intramural, means in the wall of the bladder. And actually, you can see the fistula communicating with this air. So, of course, as I, this will also show it to you. Sagittal will also show it to you. But in the exam, you have to impress the examiner by initially picking it up. So this is sagittal. You can see this fistula going, and then it goes into it. Okay, candidate one, thank you very much.
Thank you, Dr. Khan.
Candidate two, are you with us?
Sure, doctor.
Okay, this case is a 43-year-old male with fever and headache, and they are worried about encephalitis, question mark. That's the clinical.
Okay, doctor, I request remote control.
Approved?
Yeah. I'm presented by MRI examination, flare sequence of the head. I'll try to scroll first, then I'll start commenting in the exam.
Uh, you know, excuse
Yes,
me.
doctor. Sorry, doctor. Yeah.
Actually, just one second, please. I just want to make sure. I have given you the wrong history. Sorry, my notes
Oh,
are upside down. So the history is, this is a 52-year-old female, dizziness, headache, visual disturbances off and on. This is the history provided actually. Over to you.
okay, doctor. Uh, I'm scrolling now from the bottom up.
So I'll repeat that: 52-year-old female, dizziness, headache, visual disturbances. That is the history.
So this is a flare images of a brain of a 52-year female patient that complaining of dizziness and headache. I can see there is some hyper intense foci scattered in the white matter. I'm focusing now in the area of the dural venous sinuses. I can see there is some high signal intensity that I can see in the area of the mastoid air cells, and also at the area of the left transverse sigmoid sinus. However, I can see the preserved the normal flow void in the left sigmoid sinus, but there is an abnormal high signal intensity which is present in the mastoid air cells in the left side. This might signifying an mastoiditis and inflammation. I'm focusing now in the area of the middle ear. I can see also there is a high signal and fluid opacifying the middle ear.
Okay.
Uh,
Uh, look at the and look around the pituitary fossa, please.
sure, doctor. Now I will focus around the area of the pituitary fossa. I'm focusing in both cavernous sinuses. Uh, yes, I can see here in the suprasellar region, I can see that there is a well-defined lesion which appears to be iso intense signal intensity. This lesion I'm trying to check the relation of this lesion to the optic chiasm. And I
Okay,
see,
just
can
one
see,
second, please. Just one second.
yes,
Anything else you can add on this T2 weighted sequence?
yes, doctor. Here in the T2 weighted images, again, it redemonstrates this suprasellar well-defined, what appears to me an
Look at the
extra-axial.
cavernous sinuses, please. Look at the cavernous sinuses.
Yes, yes, this lesion is, I'm sorry, please, there's some jump. I'm focusing now in the area of the cavernous sinus. I'm focusing in the internal carotid artery. I can see there's mild attenuation of the right carotid, internal carotid artery. I'm focusing now on the left. I can see there may be what appears to me area of normal high signal that I need to
Okay,
confirm.
just one second, please. Just one second. I'm going to take over the mouse. What do you think
Okay.
is happening here?
Here in the cavernous sinus, I can see both fluvoid signal in both internal carotid artery is maintained. I can see the basilar artery as well. I can see the sphenoid sinus, which is well aerated. Uh, can I scroll up and down, doctor?
Yeah, of course.
Sure. Again, I can see here this well-defined suprasellar lesion. This lesion appears to be abutting the vessels, but it's separated from the vessel. This lesion appears of high signal in T2 images.
What would you like to see next?
I like to see the contrast if it's available to check if this lesion is enhancing or not.
Over to you.
Yes. So this is the T1 post contrast. I'm focusing in the four noted lesion. I can see this lesion is an avidly enhancing. I'm trying to check the relationship of this lesion to the vessels because one of the differential that might be an aneurysm that I need to rule it out. Uh, I cannot see
Okay, let me give you another sequence. Just one second, please. Over to you.
yes. So this is post-contrast coronal images. I'm focusing in the lesion. So this is a suprasellar well-defined enhancing lesion. This lesion is abutting the optic no abutting the optic chiasm. Uh,
Okay, just one second, please. I'll take the mouse from you. What is happening here?
in this image exactly. Yes.
Oh, you can scroll even if you want.
Okay.
No, don't go right and left. Just concentrate on that area where I had pointed out.
Okay. So this is the lesion I can see. Oh, what happened? Sorry. I can see this lesion. There is an caudal extension of this lesion. There is a
Okay,
caudal.
so what is your conclusion?
My,
Where is your mind going?
yeah, my conclusion for this is a suprasellar, well-defined, enhancing lesion. My primary differential diagnosis, this may be an uh, glioma. The first differential diagnosis, it will be an aneurysm. I think it may be arising from the anterior communicating artery. However, I like to confirm in the MRA images or CTA. The second differential diagnosis will be an enhancing lesion like an optic pathway glioma. Uh, uh, this is the differentials that others, which is are unlikely, like
Okay,
craniofaryngoma.
thank you very much. Let me go through it. Difficult one. Some of the cases which I have selected today is to develop your minds. I think two or three of them are quite difficult for viva. They might come in long case, but they are still to be type of cases. This is a lymphoma with intracranial extension. Masticator space lymphoma with intracranial extension. Now, what is masticator space? Masticator space is an exam space. It is very important. By definition, masticator space is this space where it is surrounding the mandible and the muscles of mastication. And please remember, it goes and touches the base of skull. And that is why it becomes extremely important. This is the masticator space once again. Now, this diagram tells you everything. Now, this is the masticator space, the purple space. It touches the base of the skull. This foramen here is an exam foramen. This is the foramen ovale. From here, next to this is the cavernous, this is the Meckel's cave. The cavernous sinus is sitting here. In the Meckel's cave, the trigeminal nerve divides into V1, V2, and V3. V1 and V2 pass into the cavernous sinus. V3 passes through the foramen ovale into the head and neck, into the masticator space. There is a concept of perineural spread of tumors. So from this space, tumors can go up, and of course they can go down like a schwannoma. That is also an exam case. Uh, and then infections can go up from here. I'll show you a few cases. This is where the masticator space touches the base of the skull. Key point is look at the foramen ovale. This is the spinosum where the middle meningeal artery. Now, this diagram tells you the same concept that the nerve forum, the V3, it passes and goes into the Meckel's cave. And this diagram tells you everything that a tumor sitting here, just like a wire, the tumor can go up through the wire upstairs into the brain. So beware of this. Anatomy is the key thing. This is from StatDX, and it tells you enhancing tumor here, which goes into the, from the Meckel's cave, it will go to the cavernous sinus, etc., etc. Now, masticator space lesions, perineural tumor extension, enhancement of cranial nerve 8 in tumor to foramen ovale and then to the Meckel's cave. Can be seen in squamous cell carcinoma, melanoma, sarcoma, lymphoma, adenoid cystic carcinoma of parotid, etc., etc. So this is again an exam case where a masticator space abscess, because please remember, mandible is in the masticator space. So a fulminant type of abscess, this patient had a dental extraction and then secondary infection. And there is a lot of phlegmon in abscesses. It goes all the way, and there is what we call a subdural empyema also. So it goes all the way. This is what we call temporal and infratemporal fossa. The old words were this, but the key concept to remember is that this is where it goes. Here you are. It goes and touches here. So that is how infections can go into the cranial cavity. So this is key concept for you to remember. From here, in this particular case, there was another differential diagnosis. Infundibular or suprasellar lesions, that's another. So this is the infundibulum. This is the floor of the third ventricle. This is optic chiasma. This is hypothalamus. There are various names here which you can remember. For example, tuber cinereum. And, there is a perforated substance. No need of remembering that. Memory bodies you can make out, but just remember it as hypothalamus. So this is infundibulum, this is hypothalamus. Once again, cavernous sinus, and V2 and V1 passes through the cavernous sinus, and V3 has gone down. And this is it. In our case, the tumor was sitting somewhere here, which was very well actually identified the location by the candidate. Infundibular lesions, lymphoma. So lymphomas can go to the stalk. So you will always consider, if there is a stalk lesion, you will consider a lymphoma. Now, let me go through the case. So it was a difficult one, and I was not expecting to pick up, but I had given a few hints. Let me explain what I was on a flare sequence. Of course, this I was not interested there. This was picked up, so there is something happening here. Now, if you develop your anatomy, this is the cavernous, internal carotid, so the pituitary is here. As I go up, this has to be the portion of the infundibulum, which is slightly thickened. Just superior to the infundibulum is the optic chiasma and the floor of the third ventricle, including the optic chiasma and other portion of hypothalamus. Now, as we go down, I had mentioned what is happening here. Now, if you compare right and left, this is the cavernous, this is the internal carotid artery. So stretch of imagination till here is the cavernous sinus. Now, what is happening? There is a lot of difference. Something extra is sitting there. Something extra is sitting there, right? And then if you go down, your protocol to look at the brain MR, please remember, after you look at the brain, you have to look at the extracranial spaces, etc. Masticator space is a key. It was a very difficult one here, but once you pick this up, and then you start thinking what is happening there, if you go down, look at the masticator muscles, look at this muscle versus this muscle. And then, though it is not a fat saturated sequence, which would have been very helpful, but even then you can make it out. Now, I had shown you a T2 weighted sequence, and the idea on the T2 was this finding was visible. Maybe on FLAIR it was visible much better. These are the memory bodies. But this finding was better seen here. This is something extra. You see, compare this and this. Now, as we go down, once again, look at the masticator muscles. Look at this muscle versus this, and this is thickened and this is enlarged. And then, of course, we saw the post contrast, which is this one. This ideally should have been a fat saturated, but this was not a fat saturated. Having said that, you can make out that there is extra tissue there. Now, this extra tissue, of course, is going here also. And then, as you see here, again, it is not fat saturated, but having said that, you can see enhancement, no enhancement. And then there was enhancement here. I had not shown you a sagittal, but now this, if you look carefully, look at this. Look at this is the muscles of mastication, and look at these muscles of mastication. They are all thick, enhancing, and then this soft tissue is going up. And so it is going into the Meckel's cave there. And with that, the infundibulum and portion of the hypothalamus is thickened. So that is hematogenous spread, not direct spread, but of lymphoma, which can happen. To call it a glioma was fine, but that was in isolation. So there were too many things which were happening. it was a difficult one. It's too what we call complex for a viva situation. But my idea is today's session, I'm just showing you MRs, sorry, CTs and MRs. Idea is to develop your mind, develop your anatomy, develop your basics, which will help you. This kind of a case, better as a long case. In a viva scenario, it is a bit too much. In any case, well done. So candidate two, next case, please. This is where I got the history wrong. And this case is 43-year-old male with fever and headache, rule out encephalitis. Over to you.
Okay, doctor. I request remote control.
With you.
Okay, doctor. This is an MR images, flare sequence of the head. I'll scroll through the images, then start to comment. So in this flare sequence, for the first instance, I can see there is some subtle flare hyper intensity, which I can see here in the right high parietal region. I can see the gray-white matter differentiation is preserved. The ventricular system is normal. The basal ganglia and thalamus.
Excellent. So what will you do next? Because of time factor, I'm asking you this question.
In this case, I like to review it in the other sequences like T2 weighted to confirm our findings, then diffusion if it's available.
So there is a diffusion, which is this one. And because of time factor, I'll just quickly show it to you myself. So this is, we are going to that area where you were interested, right? This is it.
Yes.
Is it restricting?
Yes, doctor, there is a high signal in the diffusion weighted images. If there is ABC map, I will confirm the restriction.
So now, do you think it is restricting?
No, this is T2 shine through.
Let's call the T2 shine through, right? Now, what are you going to do next? What do you want next?
Contrast if it's available, doctor.
Okay, so I'll give you a contrast. This is a contrast. Over to you.
Okay, so this is the contrast images for the same patient. I'll try to focus in the area of interest.
Just focus on that area, please.
Yes, doctor, in the right high parietal region. I can see there is a punctate foci of gyral enhancement. Yes, I can see also there is a leptomeningeal enhancement.
What is your conclusion there, please?
This is there is a leptomeningeal enhancement affecting the right high parietal sulci. In the history of fever, I'll be thinking of meningitis, encephalitis. I'm sorry, encephalitis. This maybe also differentials like maybe neurosarcoidosis, maybe lymphoma. Also, there may be if there is a history of primary malignancy, leptomeningeal metastasis should be.
What are you going to advise management-wise?
Management-wise, I like to correlate this with the clinical data of this patient. This case is an emergency. I will immediately inform the primary team and refer this patient immediately to the neurology team for further diagnostic work. workup.
What kind of diagnostic work are you going to advise?
May we can do CSF analysis.
Okay, well,
May
okay, well done. Let me take over. So this was a case of leptomeningeal enhancement due to TB. It was TB meningitis. I'll come back to this. Now, just a recap of the meninges. These are two layers of dura. One of them is attached to the periosteum, and the second one is deeper layer. They actually uh, uh, enclose the dural venous sinuses. So this is dura mater. Here, this white one is the arachnoid. Pia mater goes into, it is adherent to the brain, and this is known as, uh, sorry, the pia mater is adherent to the brain. Now, the arachnoid and pia are together known as leptomeninges, and the dura and arachnoid is known as pachymeninges. Now, uh, two concepts here which are important. One is the importance of a flare. In flare is very, an examiner is going to pick it up on or ask you on a flare sequence, because flare, you remember that in the sulci, the CSF is what we call dark. So you might lose that darkness of the CSF. When you lose that, there are two things which are most important for you to remember. And this is a differential diagnosis, sulcal flare hyperintensities. One of them is a subarachnoid hemorrhage. Please remember that a subarachnoid hemorrhage, which is slightly old, maybe 3, 4, 5, 6 days old, more or will be better seen on a flare, irony, than a CT scan, because on CT it will become isodense to the parenchyma. On the other hand, any leptomeningeal processes, which can be bacterial meningitis, which can be leptomeningeal carcinomatosis, it can be, things like fungal infections, etc. All of these things can cause leptomeningeal enhancement. So look at this case. This case is a subarachnoid hemorrhage, which is 6 days old. How do you pick it up? On a CT scan, these two scans have been done on the same day, by the way. And if you see the CT scan, you can see the sulci, there is no subarachnoid. By the way, we knew that there is subarachnoid, but I'm just showing you the sensitivity of flare in this kind of a scenario. But if you see the sulci, look at this sulci versus this sulci. This sulci, the signal is lost. Here, the signal, there is a abnormal signal. Once you see it, you are worried. It can be either subarachnoid or it can be something like leptomeningeal carcinomatosis. So you ask for contrast. Contrast is very important. Look at this case. In this case, look at this flare. On the flare, we can see these high signal intensity foci around the cerebral folia, as well as upstairs in the cerebrum. And then we give contrast and there is enhancement. And and look at this enhancement and this was, esophageal tumor and carcinomatosis actually. So please remember that meningeal enhancement has got pachymeningeal, dura, arachnoid, and then there is next page, there is pia arachnoid, which is leptomeninges. Main differentials remain the same, right? Infection, carcinomatosis, and within infection, it can be fungal, TB, bacterial, etc. But carcinomatosis cannot be ruled out. So remember that. This is a case of TB, and we have got on CT, we have got this enhancement. So, and on MR, of course, it is better seen on FLAIR. You can see this high signal. Now, our case on Osiris was, it was very well picked up, where I showed an initial flare, which was, sorry, where is the flare? This is the flare. And the key thing was to keep continuing till the top. And here one can see that, the gyrus here is high intensity. Of course, on a diffusion, it was slightly high, but there was no ADC. It was not low on ADC, so it was high, but it was a T2 shine through. And then on post contrast, it here you are, you compare this side versus this side, and you can see how it is enhancing. I have not shown you a coronal, but if I show you a coronal, you can see that it shows it uh, in a much better way. So as I'm going down, you see, look here, and you can see how this pia matter, it is enhancing and how it is dipping down into the salsa. And here also, leptomeningeal carcinomatosis. So LP should be advised. You check from the clinicians, they have done the LP, ask them to do it. Okay, now next. Candidate 2. This is a 67-year-old, acute chest pain, acute upper back pain, A&E. Over to you.
Okay, doctor, I'm requesting a remote control.
Yeah.
This is what appears to me is a CT angiogram. I'll start scrolling, then I'll comment on the images. Okay, doctor. I am presented by CT angiogram of a patient who has complaining of an acute chest pain, at which I can see that there is an evidence of dissection flap that I can see. It commences from the ascending aorta. I'm sorry, it commences from the distal arch. I need only to see the origin if it is proximal or distal to the subclavian artery. Is it available, doctor, to window a little?
Okay, just 1 second. Leave the mouse, please.
Okay.
Happy with this window?
Yes, yes, doctor.
Okay.
Okay. So in this CTA, I can see there is an intimal flap with dissection that I need only to see the origin of this dissection. If it's involving the ascending aorta, the arch, I can see, as it appeared to me, this dissection, it commences from the distal arch and involve the descending thoracic aorta, the abdominal aorta, with the formation of a true lumen and a false lumen. The false lumen here, it appears thrombosed. I'm scrolling down now. The false lumen, which is located anterolaterally, which bigger and it appears thrombosed. The true lumen is a little bit posteriorly. This is the intimal flap again. I can see here the celiac trunk, which is appear from the true lumen. There is no evidence of dissection extending into it or no thrombosis. However, I like to confirm this finding in the sagittal images. Then here I am watching now the renal artery. I can see the right renal artery appears to arises from the false lumen. The left one appears from the right from the true lumen. Superior mesenteric artery, only the remainder that I have seen. I think it's appear from the true lumen. Now, doctor, I'm focusing for the if there is an infarction. I can see there is a wedge area of the hypodensity affecting the right kidney in keeping with the infarction. I'm focusing now on the left kidney to check if there is any infarction, which is I'm not able to see. I'm trying now to focus the bowel if there is an area of hypo enhancement or area of abnormal mesenteric stranding that's suggestive of ischemia or bowel infarction,
Okay.
which
What is your
yeah.
conclusion?
My conclusion, this is a case of acute aortic dissection involving the distal arch and the ascending aorta with the formation of thrombosed false lumen. And it's complicated also by infarction of the right segmental infarction of the right kidney. This case of a case of an cardiothoracic or vascular emergency. I'll immediately pick up the phone and inform the finding to the to the vascular team. Also, I'll discuss the case with the interventional team. I think this patient may benefit from control of hypertension and EVAR also, endovascular aneurysmal repair.
What are the types of, give me the Stanford classification.
The Stanford classification. Stanford classification. This type will be Stanford A because it involved the distal arch and the descending thoracic aorta.
You mean to say B, correct?
Uh, uh, Honestly, doctor, I need to see the
Right.
coronal images to.
What is the definition of B?
The B, it's involve only the descending thoracic aorta and not involving the ascending aorta or the arch.
What is the treatment usually for B? Is it surgical or is it medical?
B usually it's a medical control of hypertension and
Okay,
surgical
thank you.
or.
Thank you.
Thank you.
So this was a aortic dissection. This is the, of course, you can refer to Radiopedia from where these diagrams are. And there is more than what I have shown here, but just to keep it simple, because there is another type which is in between these two. But having said that, if ascending aorta is involved, then that is type A, and B is distal to subclavian. This is surgical, this is medical. And these are questions which can be asked in the exam. Now, you did very well where you describe the various, when you get this kind of a case, what you need to describe is what the candidate did very well. True lumen and the false lumen concept. True lumen, by the way, is the lumen which is supplied by the left ventricle. So this is the left ventricle, and you can see the contrast is now the ascending aorta is not involved. There are some artifacts here, and we go there to the arch, and then from here onwards, distal to the subclavian, you can see it. Now, this is the true lumen. So this is the true lumen, and this is the false lumen. And here, as we are coming into the abdomen, this is the true lumen, this is the false lumen. And here, it was very well demonstrated or described by the candidate, celiac artery, and then the SMA. The key thing is that the false lumen is supplying the right kidney, and the right kidney's health is not good. It is, infarction in evolution. Here, corticomedullary differentiation is seen. Here, it is not. So that was very well picked up. It was also very well picked up that the left kidney is normal, and then the distal extension. So portion of it goes into the right iliac. And then the pertinent negatives, as gut is involved and things like that. So overall, this was very well done. Thank you, candidate 2. Candidate 3, are you ready?
Thank you.
Yes, Dr. Khan, I'm here.
Okay. Do you do MREs?
Yes, sir.
So I am going to show you an MRE, right?
Yes, okay.
This patient is a 54-year-old male, and correction. I am. So this is a 41-year-old female with chronic diarrhea,
Okay.
chronically unwell, and for further evaluation with MRE. Over to you.
I'm presented with a coronal scan, T2 of a female patient with the chronic diarrhea. There is quite a normal distension of the small bowel loops, I believe, with mannitol, and there is abnormal ISO intense signal intensity seen central dendrite iliac fossa involving both sides of the mesenteric side and the colon and the mesenteric side of the terminal ileum and the cecum with heterogeneous intensity. In my routine practice, I will request also the Viesta image, Viesta sequences, or an axial T2, please.
Just 1 second, please. Just 1 second.
Okay, I'm trying to scroll now.
So
I can scroll now.
just 1 second. I'll
Okay.
show you two axials. One is for upper abdomen and then is for lower abdomen. This is upper abdomen axial. Then I'll
Okay.
show you lower abdomen axial. Over to you.
So on the upper abdomen, there is quite normal distension of the small bowel loop. I can see only few small lymph nodes in the mesentery. There is abnormal mural thickening seen involving the jejunal bowel loop, displaying iso-intense signal intensity in this sequence in T2. This could represent an inflammatory process. I would like to look for also the liver and spleen and gallbladder stones also. Liver looks...
Don't worry about liver, and we know that there is a bit of fatty liver and gallstone.
Okay.
We are not interested.
Okay. So this is a mural thickening involving the proximal jejunal bowel loop. I would like to see it on the also diffusion weighted image and the post
Just 1
contrast.
second, please. Just
And
1 second.
Okay.
I am going to give you the subsequent T2. Over to you.
So in this T2, I'm scrolling from down up. This rectosigmoid looks normal. Uterus looks with some signal intensity, maybe adenomyosis or something. I can see here on the right iliac fossa, there is abnormal mural thickening involving the both sides of the terminal ileum. And also I can see there is abnormal communication between our fistula tract between two opposing ileal bowel loops. This could represent an enteroenteric fistula. In this setting, I'm worried about Crohn's disease with a complicated enteroenteric fistula. And also we have a skip lesion on the proximal jejunum. In my routine practice, also I will look for gallbladder, and there are multiple stones. I'm also checking the...
Just 1 second, please. Just 1 second. Leave the mouse. Leave the mouse.
Yes,
Leave the
yes,
mouse.
Dr.
Post contrast. Over to you.
Post contrast fat saturated image confirms the enteroenteric fistula.
You can move the mouse, please.
Yes, I'm trying, Dr. Yeah, okay. Oh, sorry.
Just 1 second. The window is out. I will reset the window. Now you can move the mouse.
Ah, it's moving here. Okay. So it confirms sorry. There is abnormal stratified enhancement seen involving the terminal ileal bowel loops, mainly on the mesenteric side. And this is the trilaminar enhancement, which means this is acute on top of chronic exacerbation of Crohn's disease. And also I can see there is some fatty proliferation surrounding
Okay,
the
just 1 second,
region.
please. Just 1 second.
Dr. Khan, can you scroll for me, please? Because I think it's very
Yeah,
hard.
so okay, I am now going to scroll
Will
for
be
you.
much faster. Yeah. Okay.
This
Thank
is
you.
a T1 weighted
Yeah. So
post
I would,
contrast.
yeah.
Just hold on. Let me give you a few points and then I'll ask you to take over. So I am going to show you two scans, axial, post contrast. This is upper abdomen. Just keep
Okay.
looking. Just keep looking.
There is this is the one with a abnormal enhancement on the right side. There is a skip lesion on the right side as well. There is abnormal enhancement in the bowel loop. So this is confined with the skip lesion of Crohn's disease. So we have multiple segmental small bowel involvement, but the chronic involvement, chronic disease is in the ileocecal region with enteric fistula and fibrofatty changes. I'm looking also for the sacroiliac joints to see if there is any involvement. The enteropathic type of sacroiliitis also could be a possibility, but I cannot see any involvement here. There is no mesenteric abscesses, and there is no other fistulas either with
What
the
is
blood.
this?
Um, could be a calcification or appendiculus, or this is the sinus tract itself.
Okay. What is this?
This could be the appendix.
Okay,
Yeah.
fine. Thank you.
Okay.
Let me take. This was also a very, very busy scan, not ideal for a viva scenario. But again, this is a long case type of a case. I just wanted to teach you. And in any case, I will go through it. Now, so this was complex Crohn's disease with multiple fistulae. I just want to show you a few cases of Crohn's disease on, let's say, barium examination. They can show you barium meal follow through. They can show you barium enema. So in Crohn's disease, what happens is that with passage of time, there can be many fistulae. And these fistulae is what they are, asking you to pick up. For example, in this case, we can see, look at this tract here. Now, this is the original ileocecal junction. There is a ileocolic fistula, ileocolic fistula. Now, with that, you can see contrast tracking into the bladder. At this point, contrast should not have been tracking into the bladder. If you look carefully, there is faint contrast here, means that there is a ileovesical fistula. And if you see the sigmoid colon loops, they are adherent to these jejunal loops. So there must be a ileocolic fistula at that site also. Another example where we can see this is a barium enema examination, where we can see this is a loop of the small bowel and there are two fistulous communications, and this is a chronic type of structure there. Another example, which is follow through exam, this is a follow through or delayed film of
Yes. I'm presented with the sagittal T2 scan of lumbosacral spine of skeletally mature patient. I can see there is abnormal signal intensity of L4, L5 disk space, and there is abnormal high signal intensity seen also opposite L5 in the extradural space. There is abnormal high signal intensity within L5432 at the pedicle of L2. I will confirm that on T1 as well. I'm going all the way to the parasagittal plane on the foramen. The keyhole here, fat is preserved except for the L4, L5. It's obliterated on the, I'll check if this is the right or left side on the synchronous image of the axial scan. I'm going the other way. The keyhole here is normal. So I would like to see also the T2 axial.
T2 axial.
Yes.
Just 1 second, please. This is a T2 axial, and because the level is not projecting to you, I will guide you there. This is L4, L5 level where you were interested. This is that level. Over to you.
Oh, there is a indistinct margin of the extradural space at this level with abnormal iso-intense signal intensity lesion seen at the extradural space, obliterating the L4, L5 exit nerve root and compressing it on the left side. There is also abnormal facet arthropathy at this level. I'm trying to scroll down now. It's not moving. Yeah. Yeah. The psoas muscle looks normal. I'm scrolling down to the sacroiliac joints. In my routine practice also, I would like to see the T1 post contrast.
Okay, what's happening to the nerve roots on this T2 within the thecal sac?
It's thickened and it's compressed on the left side.
Okay, I will give you more sequence. Just 1 second, please.
Okay.
Post contrast, over to you. You can scroll, please. Yeah.
So in the opposite, I believe this is L5 because I can see the iliosacral ligament. There is abnormal.
This is L5S1. Yes, you are right.
Yes, yeah, there is abnormal triangular shaped intradural lesion which is not enhanced, and there is abnormal obliteration of the anterior extradural space at this level. So also compressing the thickened coda equina roots at this level. So this could represent a subdural abscess, and also I can see here also there is abnormal enhanced anterior extradural lesion. I'll confirm that on the sagittal as well. So this is an extradural abscess and intradural, yes. So we have here multiple anterior extradural abscesses starting from L3 down to L4 and 5 and extending to the upper surface of S1.
Well done. Thank you. Thank you. Well done.
Yeah, thank you.
So this is spondylodiscitis with epidural as well as subdural abscess and phlegmon. Very well picked up that there was an epidural and subdural, and this is, approaching full marks because of that. So well done. Now in your book, epidural phlegmon abscess. This is 2.17, which covers whole of the spine. One thing which I want to highlight is the concept of phlegmon versus abscess. Just remember that phlegmon is sort of inflammatory mass. Phlegmon is, precedes an abscess formation. And sometimes phlegmon might not develop into an abscess. So because of antibiotics, etc. In phlegmon, everything will be enhancing. And abscess means necrosis and means the classical finding, whichever part of the body you are. It's a classical scenario. This concept is important for you to remember in various kinds of, for example, even in head and neck, abscess versus phlegmon. So the clinicians are going to ask you, is there an abscess? If there is an abscess, it can be drained. Phlegmon cannot be drained. And you might have to wait or rescan, or at times you don't need to. So this concept is extremely important for you to remember. Phlegmon versus abscess. Even in liver, the same concept. If it is not liquefied, even on an ultrasound, you cannot drain it. You wait for the weekend, wait 48 hours, do another ultrasound. If it is liquefied, means then you drain it. So this is, the epidural. Now, this is, I'm showing you a T2 weighted sequence, a stir sequence, a T1, uh, and a T1 fat saturated. If you look carefully, as far as marrow signal is concerned, marrow signal will be high on stir and low on T1, and the intervertebral disc might have more fluid than usual. But the key thing is this, phlegmon. If you see, this is it, and on post contrast, this is the phlegmon, and it enhances on post contrast. Sorry, this is not a fat saturated. This is a post contrast without fat saturated. So it's not an ideal sequence. This one is something here, which is fluid signal on this T2 weighted sequence. And then there is surrounding enhancement. So this was an epidural abscess. Now, our case here. Now, if you see here, it is in the same cat. Just 1 second, my Osirex has crashed. Actually, it is showing, but it has crashed on my screen. Just 1 second. I hope everybody can see. Candidate, you can see it now, the screen, right? Can you?
Yes, yes, yeah.
Okay, so this was very well picked up. If you see here, there is something dirty, this cauda equina, something, the nerve roots are there, they are sort of jumbled up. If you look carefully, there is something extra happening there. It's not like CSF. There is something extra, but we cannot pick up more than that. On a T1 weighted sequence, which is this one finding is that, if you see the end plates here, there are low signal. Please remember, on a T1 weighted sequence, the formula is that the marrow signal should not be lower than the adjacent intervertebral disc. If they are lower than the intervertebral disc, then that is considered abnormal. May it be for infection or infiltrative lesions. I don't think so. I showed you in stir sequence, but if you had asked, I would have shown you, but you did not need it. So don't worry about that. Now, on the stir sequence, this is same thing, which was low signal on T1 is high signal on stir sequence, means the marrow is abnormal and the disc appears abnormal. So initially, you asked for an axial, which I gave you. But just for a recap, let me go through the sagittal T1 weighted sequence. Post-contrast, T1 fat saturated. So if you see here, abscess here, abscess here, abscess here. The key thing is that all of these abscesses are extradural abscesses. Even here, there is an abscess. This one here is a subdural abscess, and this was very well picked up. And on post-contrast, there is a bit of enhancement of the end plate, bone marrow enhancement. There is a bit of enhancement of the nerve root here. Actually, there is some abscess sitting here also in the presacral space. And some of the nerve roots are enhancing. Now, if we go for this T2 weighted sequence, the key finding is that subdural abscess. You see, something is sitting there and the nerve roots are here. On a T2 weighted sequence, as I go superiorly, then the thecal sac is visible. And here, there is something extra, which we will see with post-contrast. But as I go to L5 level, you can see this triangular high signal intensity focus. On post-contrast, this is epidural. Surrounding that, there is enhancement. But in the lowermost portion, there is a subdural abscess. So that was the key. Well done. Okay, because of time factor, I am going to rush you through the next of the, rather this case. So this case is a 39-year-old 68-year-old male, right trigeminal neuralgia. Over to you. Can you ask for the mouse? Are you with us? Candidate 3. Have we lost you? Let me check. Candidate 3 is lost, I think. Make a co-host. Candidate 3, are you with us? Hello, hello.
Yes, you can hear me, Dr. Khan. Sorry for that.
Oh, now we can. Okay. So
Sorry
because
for
of
that.
time factor, I am going to push you on this case. Over to you.
Okay, thank
This patient is a 68-year-old male presented with trigeminal neuralgia. So they did a CIS sequence for that. Over to you.
Okay, Dr. Khan, can you scroll for me, please? Sorry for that, because
Okay.
my computer has some technical difficulties here. Okay. Okay, so in this axial T2 CIS sequence, I can see there is a extensive soft tissue mass.
Candidate 3, are you speaking or you are silent right now? You know, I think we will let you go, candidate 3, because we cannot hear you, and I presume that you are speaking. Hello. Okay, so let me take over this case because I don't think so the candidate is there. I'll start with the next next case for the next candidate. Now, this is a beautiful case if you want to learn. Unbelievable. And I don't think so we should have found this case in UK. I think this case must have had some social issues or something presented so late. But this happens with nasopharyngeal carcinomas, where nasopharyngeal carcinomas can, at times they are asymptomatic, but this one is terrible. because it is doing so many things. So before I go through the case, this is a nasopharyngeal carcinoma. Let me go through a bit of anatomy with you. This is also quite this is a case in which I want to teach you something. So just listen, because you are going to learn the base of skull anatomy and a few 2B cases which have come in the exam or can come in the exam. Nasopharyngeal carcinoma with intracranial extension. It was a huge one. So this is the nasopharynx, this is the clivus, and this is, of course, the sphenoid sinus. Now, posterior to that, of course, is the brain stem. And as far as bony anatomy is concerned, this is the soft tissue anatomy rather. This is the nasopharynx, and I'm not going into the the details of the anatomy, but I just want to revise the overview. So this is the bony anatomy. Posterior to the nasopharynx is the clivus. Portion of the clivus is made up of the occipital bone. Portion of it is the sphenoid bone. Sphenoid bone also makes the sella. This is the posterior clinoid process, anterior clinoid process, floor of the sella, and the the sphenoid sinus. Now, concentrate on this. And this is what this case is about. Because what happens is, in this case, that it erodes from the nasopharynx, it erodes into the intracranial cavity, and it takes out many things. Now, on this axial, if you see, this is the sphenoid bone, this is the temporal bone, and this is the occipital bone. Now, occipital bone has got various parts. The part of the clivus is made up of it, and this is the squamous portion. Now, this sphenoid bone, of course, this is the posterior clinoid process. This is the pituitary fossa. You can imagine that the cavernous sinus is sitting there. The pituitary will be sitting here. The cavernous will be sitting there. And this is somewhere here is the Meckel's cave. And this is the foramen ovale. From the Meckel's cave, the V3 will go down. And this patient presented with trigeminal neuralgia. So, of course, everything was gone. This Meckel's cave was gone. And this is the anterior clinoid process. This is the optic foramen. This is the planum sphenoidale. This is foramen rotundum. So, this is the trigeminal nerve. Two of the branches, they go into the cavernous sinus, V1, V2, and V3 dips down. Now, just concentrate on the trigeminal, V1, V2. They are going anteriorly. This is the fossa. This is the groove for the internal carotid artery. So the cavernous sinus is sitting all the way here. And this is the V3. And this is on coronal, where we can see the cavernous sinus, the internal carotid artery, and the nerves which are within the cavernous sinus. Clivus lesions. And one of the clivus lesions is a nasopharyngeal carcinoma, may invade and destroy clivus and intracranial, plus minus intracranial extension. In this case, there is another concept which I warn you is a 2B concept. This is a motor denervation. Now, motor denervation of the tongue, I think I showed you a case, if I'm not wrong, 1 or 2 weeks ago. Motor denervation of the tongue, hypoglossal nerve, is an exam case. And I'll show you, because in our case also similar findings are there. The concept is that when this tongue, when there is the word motor denervation can happen in any part of the body. But when it happens to the hypoglossal nerve, there are changes in the tongue, in the hemi-tongue. Initially, it will be like edema. High signal on stir, if you give contrast, it will enhance. Then it will become subacute. The stir sequence stir will not be as high, and there will be some fatty infiltration. In chronic, it will become just fatty. And this particular case had a jugular foramen tumor. Actually, that is a different case, and this is a different case. But this is from your Chapman, where you should have a clear-cut idea when there is motor denervation, then how the signal of the tongue in this case can change. And in acute, less than 1 month, high stir and increase enhancement. In subacute, which is 12 to 20 months, decrease edema and stir mild enhancement. In chronic, it will become fatty. And this is one case where the tongue has become fatty, and this is a stir sequence where the tongue has got high signal. So with this background, look at this case, which has got too much of things to learn from. If we just concentrate on this cis sequence, which is done as a routine when you do trigeminal neuralgia. Now look here, this is the pons and this is the trigeminal nerve. This nerve is going here. Now where is the nerve? It is completely compressed, but then everything else is also gone. Actually, the epicenter is in the nasopharynx. So from there, it goes back like this. It is destroying, you know, here is the masticator space. Part of it is extending into the masticator space. Now, if you see the clivus is gone here, and lateral to the clivus is the sphenoid portion of the temporal bone, and the carotid canal. All of these things are destroyed. And as we come superiorly, the key thing, this is the carotid canal, and the carotid canal actually on the right side is not visible. This is the cavernous portion of the internal carotid artery, and this is the cavernous sinus, and all of this is replaced by this mass, which actually continues in the middle cranial fossa and goes superiorly. And key thing is, exam thing is this one. Now, if you look carefully on this T2 weighted sequence, you can see the same thing, but look what is happening to the tongue. Part of the tongue is fatty. And why is it fatty? It is fatty because the tumor has gone and invaded the base of skull. At this point, at the base of skull is the jugular foramen. This is the carotid space. And next to the jugular foramen is the hypoglossal nerve, which goes into the carotid space. So the hypothesis is that the hypoglossal nerve is destroyed. And that is why there is motor denervation in the supply of the hypoglossal nerve. So this case per se has come in the exam, I warn you. Jugular base of skull lesion with epicenter in the the jugular foramen in the carotid space, and with that motor denervation. So it's a very busy scan. I can teach on this for the next 1 hour, which I will not do because you don't require that much, but I just wanted to show you as an example of motor denervation and a bit of revision of the anatomy of the base of skull. So this is it. Now, candidate 4, are you with us? And by the way, this was the CT of the same patient. This is the CT. I am still surprised that why did this patient not report for some, medical advice? Must be sitting at home for ages. Now, candidate 4, are you with us?
Yes, sir.
Okay, so this case is a head injury. The patient is a 39-year-old male, road traffic accident 8 days ago, severe head injury, bilateral pelvic fractures, both femoral fractures, tibial fractures, had a subdural hematoma, which was tackled conservatively. The patient has got low Glasgow coma 7. Now, from a hospital, from a slightly peripheral hospital, was shifted over for care because, the next of kin also belonged to this area. But the patient was not well. So this is a flare sequence. Over to you. Patient has got GCS 7. Over to you.
Yes, can
Previously,
I
MR was not
request for the
available.
control?
Yeah, please request.
Okay, I have requested.
Yes, I have approved.
Okay, I have been presented with an axial scan through the brain flare sequences, which shows a subdural hematoma
Just
on the
1 second,
posterior.
please. Just 1 second, because of time factor, I will just tell you something that I will show you something which is, I am not interested in that subdural, right?
Okay,
This subdural was a high signal
already
on
known. Yes.
P1 weighted sequence. So uh, now we are worried about that GCS7, what is happening. So that's why this scan has been done. Over to you, please.
Okay. I can appreciate that there are few scattered small foci of T2 hyperintensity at periventricular location at bilateral deep white matter. It could be related to chronic ischemic changes. I can appreciate that there is another lentiform shaped hyperintensity in the right basal ganglia at the globus pallidus, uh, which can be an acute infarct as well, but I have to confirm it in the other sequences. Let me scroll through the other sequences, to the other levels actually. I'm scrolling down. Now I'm at the level of the cerebellum and the brainstem. I want to look for any specific injury of the brainstem. There is some heterogeneity uh, along the occipital bone, but and bilateral mastoid cells show some fluid as well.
Look at the brain parenchyma, please. We are looking for cause of the low GCS.
Okay. I'm further scrolling up. Um, I'm still uh, searching for any intracranial acute infarction or any injury or any laceration, but I cannot find. There is no midline shift. There is no hydrocephalus
Just 1
seen.
second, please. Just one second.
This
Can I
insular
stop you?
this
I
insular
stop you?
cortex appears. Yes.
Excuse me. Can I stop you? I'll ask you a question.
Yes.
What do you think is happening here? What do you think?
Uh, these are hyperintense foci seen in the bilateral periventricular deep white matter, and I can also appreciate that some of these foci are seen in the subcortical region, and these could be. I have to actually further confirm them in other sequences like GRE to rule out diffuse axonal injury in this post-traumatic case.
Which sequence would you like to see?
I want to see GRE sequences, if those are available, so that I can appreciate that there are signal voids.
Okay, over to you.
Okay, so many of those high intensity foci on the flare sequences show signal void on GRE sequences. I am suspecting um, uh, micropunctate hemorrhagic foci, which would further warrant diffuse axonal injury in this patient, but the splenium was normal. These scattered foci were also identified in the cerebellar region as well. And
So
there is a
in the
high
cerebellum,
and there is yes, yes,
in the
yes, yes.
cerebellum, can we explain it on grounds of diffuse axonal injury?
U- Usually these areas are not particular for diffuse axonal injuries. Can I have diffusion varied imaging as well in this matter?
Yeah, it was nothing there on diffusion and nothing there or any other sequence to add to
Okay.
this. There was no finding there.
Okay. In this particular scenario, it could be related with early ischemic changes, but they are not seen.
Hint. The patient had multiple fractures.
Okay, so these could be multifocal fat embolic
Okay,
related
stop there. We
ischemic
stop
changes.
there. Okay, then, thank you. So, fat embolism post-trauma, but there were diffuse axonal as well as this. Now, microhemorrhages on MR, there is a huge differential diagnosis. And please remember fat or air embolism, both fat embolism particularly. Please remember that fat embolism, if a patient has got bilateral fracture of the femur, I think if I'm not wrong, between 1 and 3% are chances. I might be wrong, you can Google it or Radiopedia it. But it's not very uncommon. And the fat emboli, they go into the lungs, the skin, and the brain most commonly. It can go to other places. And in the brain, this is the finding which you are shower of low signal, because it can show restricted diffusion in acute phase, but usually that is lost within 1 or 2 days. But the microhemorrhages is what you are talking about. So in this case, the scenario was that the patient was shifted from somewhere where the MR was not available on, there were non-specific high signal intensity foci on FLAIR. One cannot, vouch for more than that. But on this sequence, you can see, innumerable number of these low signal intensity foci. Some of these might be diffuse axonal injury, fine, particularly this one subcortical, but please remember that cerebellum is a rare site. If you go to academically speaking, 4 sites in diffuse axonal injuries are more common, which you should remember for your 2B, like subcortical, gray white matter junction, then corpus callosum, internal capsule, and brainstem. Brainstem has got the worst prognosis, but academically speaking, diffuse axonal injuries can happen anywhere. And they can happen in the cerebellum also. It's a rare site, but it can happen. Counter argument is that they will not be so much. This is just a shower of it. So it can be explained on grounds of fat embolism. That is what this case was about.
Right.
Okay. Now over to you. Next, this is a 66-year-old male, pain abdomen, weight loss. Over to you.
Okay, I have been presented with axial post-contrast CT
Can you
examination
ask?
through the
Can
abdomen.
you ask for the mouse or you can scroll? Just try it.
I cannot scroll. I have to ask for. Okay, I have requested it.
And I have approved it. It is with you.
Okay, so I am looking at the axial post-contrast CT scan through the abdomen. Here I can appreciate that there is a cystic abnormality in the epigastrium. Let me just scroll it. Okay, so there is a soft tissue abnormality identified, likely involving the pancreas, head and neck region, with associated adjacent large exophytic cystic component as well. I can appreciate that the lesion is locally invasive with associated pancreatic ductal dilatation as well as intrahepatic biliary channel dilatation as well. The background pancreas itself appears atrophy. The soft tissue itself is likely invading into the adjacent bowel loops with encasement of the vessel. Let me just check it out that which vessel is it. It is actually encasing the SMA, as well as the portal vein at the level of the splenic confluence with associated encasement and narrowing of the SMV. I am suspecting a primary pancreatic carcinoma with double duct sign, and it is locally invasive and likely surgically irresectable on the basis of imaging.
Okay, that's fine. Well done. I'll take
Right.
over and describe it and the findings. You did well there. Now, this is case 11, mucinous cyst adenocarcinoma pancreas. So nobody is asking you to classify it like this, but why is it a mucinous cyst adenocarcinoma? I will tell you. Now, key concept of pancreatic tumor is that pancreatic tumors can be solid and they can be cystic. Please concentrate on this slide. Solid tumors can be, pancreatic carcinoma or pancreatic neuroendocrine lesions. Neuroendocrine is a different world because they enhance on arterial phase. Pancreatic carcinoma does not enhance. They enhance. And then insulinoma, gastrinoma, somatostatinoma, ACTHoma, etc., carcinoid, etc., etc. And they can be benign, they can be malignant, they are favorite for the exam. There are a lot of cases about them, but I'm not showing you because I am in this world right now. Now, cystic neoplasm, the key thing is serous cystic neoplasm, mucinous cystic neoplasm. Then there is intraductal papillary mucinous neoplasm. And then in young age group, there is a rare tumor, solid pseudopapillary neoplasm. This is in very young patients, less than 30 years of age. Now, key concept to remember is that serous cyst neoplasm, that sponge-like lesion, it is a benign lesion which does not change into malignancy. On the other hand, mucinous cystic neoplasm can convert to malignant mucinous cyst adenocarcinoma. And similarly, intraductal papillary mucinous neoplasm can convert to adenocarcinoma. I don't have time to teach you everything about these, but of course you should know. I am showing you a tumor which is this one, cyst adenocarcinoma. But having said that, even if you don't say this and you just say that this is a pancreatic carcinoma, it's fine. The job is done. Once again, I repeat that serous cyst neoplasm does not change into, there is no malignant counterpart of it. Now, look at this. This is a beautiful case, which is a discrepancy case where we just reported it as a cyst replacing the the pancreas, and this might be a pseudocyst. Is there history of pancreatitis? This was the report. And without realizing that there are stigmata of other things here. For example, if you see there is an enhancing septa, and if you look carefully, there is this soft tissue around the celiac artery. And if you look carefully, there is also a portal vein thrombosis. So this is a mucinous cyst adenocarcinoma. It is not at all a simple pseudocyst. Pseudocyst will not have an enhancing septa. Of course, the solid component will not be there. Now, when you are looking at a mucinous tumor, one key thing to remember is just consider it like ovary. In ovary, this is a mucinous cyst adenocarcinoma of the pancreas. If this was an ovary and you had to, what I mean is that this is an ovarian cyst. When there is enhancing component septi, you call it, signs of potential signs of malignancy. So similarly here also, you can call it malignant. Now, let me describe the findings in this case. So on an axial sequence, now, first of all, if you see the pancreas itself, now this is portion of the pancreas is atrophic, cystic component here. Then there is an exophytic cystic component here. If we just consider the cystic component, there is a bit of enhancement where I am pointing out. Now, with that, it is replacing, encasing the parenchyma. It is infiltrative. Now, two arteries you have to always define in a pancreatic carcinoma. One is the first artery which comes to, when you are coming from the thorax, come into the abdomen, the first artery which will go anteriorly is the celiac artery. Now, the celiac artery here divides into the hepatic, common hepatic, and the splenic. And you can see that this splenic is completely encased. And on the other hand, the common hepatic is also. It's a very ugly tumor. If the celiac artery is encased, it becomes a T4 tumor. You cannot do any surgery. And then if we go slightly more inferiorly, this is the SMA. Always comment on the SMA. So in our case, the SMA is not involved. Then look at the CBD. Actually, double duct sign was mentioned. I think, everything is replaced by the tumor. It's all eaten up. Part of it is necrosed. So that necrosis is causing prominence of duct, if you want. Now, this is the common hepatic, the CBD. If we trace it, we are tracing it as it comes close to the head of the pancreas, then we lose it. So it is compressed here, and there are some lymph nodes where I'm pointing out. Now look at the veins. So this is the portal vein. Let's trace it backwards. So this is the portal vein at the porta hepatis. As we are coming here, this is the origin of the portal vein. The origin of the portal vein. So here we are expecting splenic vein, and SMV we are expecting. Already you can see that it is indented and compressed by the tumor, and then it is completely lost. You see, it is completely lost. Portion of the splenic vein, you don't see the splenic vein then. And there are collaterals right and left. As far as SMV is concerned, if I trace it downward, sorry, I'm going. So here you lose it. It's a very good idea when you're doing your day-to-day reporting to also see it on a corona. Pancreas should be looked at on the corona to give you everything and confirm the findings. It will always add to what you pick up on. Just 1 second. I think I am into a arterial type of phase. Now I'm in a better phase. So if you see here, this is the portal vein, and you can see how it is impinged. It is completely, this is all tumor, very ugly. And this, on the other hand, is the SMV, which is completely compressed. The portal vein is compressed. The tumor is going right and left. This is the CBD, which is compressed. So it was an inoperable tumor. These kinds of cases will come in the exam, usually in long cases, where there will be multiple findings. Bone metastasis, lung metastasis, liver metastasis, things like that. So beware of that. And the marks will be given according to the findings which you have picked up. But if I just give you this one, then I will give you, how will I discriminate between a passing candidate versus somebody who gets 8 out of 8 is by the findings. So this is a key thing in FRCR, that some cases are in which the findings are very obvious and to pass it is fine, but to get more marks in it, you have to be very elaborative. So that was well done. Last case of the day. So, candidate 4,
Yes,
55-year-old male, acute neck swelling and pain. And he is a known drug abuser, by the way. So he has presented with acute neck swelling and pain. Over to you.
okay, so I have been presented with axial CT imaging through the neck, which I can see that there is gross dilatation of the left vascular structure. I am presuming it as interjugular vein. Let me just follow it through it. So yes, this is a large vessel which is relatively less enhancing, and it is tracing till the union and confluence with uh, the left subclavian vein, and this is an enlarged, partly thrombosed, actually fully thrombosed interjugular vein. Uh, and this is likely infected in nature, in background of the history of the patient. I can also appreciate that the uh, sternocleidomastoid muscle has been thickened with associated significant surrounding fat standing, which is appreciable in at the left side of the neck throughout the course of the interjugular vein. I want to trace it further ahead through the skull base, uh, as well as into the intracranial compartments. Uh, I'm looking for any evidence of transverse or sigmoidal dural venous sinus thrombosis, or any extension of this inflammatory change into the brain, but I cannot find any. The masticator and infratemporal spaces appears uh, clear bilateral pterygoid muscles are obscured due to metallic artifacts. Apart from that, the contralateral neck uh, appears clear.
So what is your conclusion?
So this is a likely infected thrombophlebitis of the interjugular vein in this patient, and I would further refer this patient to the emergency department and discuss my findings.
So, sorry, The findings are
infected thrombophlebitis of the internal jugular vein. I couldn't
thank you.
remember the terminology you use for that.
Okay, thank you. Well done.
Right, right.
Well done. Now, let's go through it. So this was internal jugular vein thrombophlebitis. So when there is inflammation, you call it thrombophlebitis. And this will be acute thrombo. In head and neck, usually it will be for first 1 week, and then the inflammation will reduce, and then you will call it, the word thrombophlebitis means with thrombus, there is inflammation. Now, carotid space in head and neck radiology, key concept is spaces. So you have to identify spaces, and with that, differential diagnosis. There are 3 spaces. There is a concept of in neck. We divide the neck in head and neck radiology into suprahyoid and infrahyoid neck, superior to the level of the hyoid bone. And there are 3 spaces which go from inferior to superior. One of them is the carotid space. And so the carotid space is important because it goes all the way to the skull. Actually, the carotid space goes from skull base to the superior cornu of the. So this is the suprahyoid correction I am looking at here. Carotid space from the base of the skull to the aortic arch, from the aortic arch till the base of the skull. So the key thing is that at the base of the skull, it goes and touches the jugular foramen. And this is a very important FRCR level where, things like glomus jugulotympanicum, glomus jugulare, etc. And also a schwannoma in this region. So this is all carotid space. Now, these are the contents of the carotid space. Internal carotid artery, it is in suprahyoid neck. Infrahyoid neck will be a common carotid artery. Then internal jugular vein, cranial nerve 9, 10, and 11, 12, sympathetic plexus, and some deep cervical lymph nodes. And so this is the carotid space at the level of the nasopharynx. And this is at the level of the oral cavity. And then in infrahyoid neck, also the carotid space continues, and it continues next to the visceral space. So this is the key concept in head and neck. What is the epicenter of the lesion? Which space is it? And then you can offer a differential diagnosis. Final diagnosis will be on the basis of radiological features and clinical history. So these are the lesions in the carotid space. Carotid body paraganglioma, schwannoma, jugular vein thrombosis. So these are the top 3 which you must remember. Now, this is a a carotid body tumor. We can see a very, very vascular lesion. This is the internal common carotid, and then at the bifurcation, you can see this huge lesion surrounding it. And this, on the other hand, is a schwannoma of the carotid space. But the but is that in cases of infection is very important for your 2B. And the candidate did very well, where the candidate was searching for a cause. And in a classical exam case, there might be a second finding, which will be the cause of this jugular vein thrombosis. The case which I showed you intentionally was more simple, but I just wanted to see if the candidate goes through this protocol of telling the examiner, which is me right now, that I am looking for a source of this infection. So he will get marks for it, even if there is no, in the case which I showed you, there was no other stigmata. This is a classical case, exam case. Here, what is happening that there is jugular vein thrombosis here. Do you see this? There is a filling defect here, jugular vein thrombosis. What is the cause? There is a retropharyngeal abscess here. A retropharyngeal abscess is sitting there, and that is the cause. So, as far as, let me go through the case. Something wrong at my end. It's not behaving. Yeah. So if you see here, this is the carotid space. So this is the jugular foramen. As I'm tracing it down, so this is the internal jugular vein, and there is artifact which was well tackled by the candidate. Now this is the jugular. Now as we come to this is the sternocleidomastoid muscle. Now comes a filling defect here. And then as you go down, there are some filling defects, etc., some enhancement, and it increases in size. The key finding is increase in size. It will be distended. Then there will be perifocal fat stranding. And this fat stranding will go into the surrounding structures. So there is inflammation, which is of the sternocleidomastoid muscle. It is all thick and enhancing. Dirty fat is surrounding it. There is no abscess formation. So I warn you, the case in the exam will be more, might have more findings, as I've shown you on the PowerPoint format. And if you see here on the coronal, you can see that how it is behaving, And a chronic, you know what happens? Interestingly, a chronic thrombosis presents like a mass. The patient will come to you, I've got a mass, it is hard, because there will not be even thick, any tenderness or anything. So this versus this is it. Okay, then, thank you very much. That is it for the day. And next Thursday, I think I will take a, I think it will be me who is going to take it. And then we are, UK IO, which is starting the week after. So we are there for 11 sessions. I'll put it on Instagram. We are doing about 11 odd sessions. So those of you who can attend UK IO,